I'm Elena Anghileri, working at Besta Institute in Milan as a neuro-oncologist and a leader in subdomain spinal cord astrocytoma in EURACAN network. I will present a lesson titled Intramedullary Spinal Cord Tumor. I have no conflict of interest. Here the summary of the presentation. After a general introduction, I will talk about spinal tumors classification and focus on the intramedullary spinal tumors, in particular spinal cord astrocytoma and ependymoma. I will go quickly through spinal canal anatomy. As everyone knows, spinal cord is an integral portion of central nervous system. It lies within the spinal canal and extends from the brainstem to the lower back, till the lumbar region at L1, L2. At the axial section, you can see the spinal cord is composed by white matter and gray matter as an H-shaped structure. The spinal cord is 0.6 to 1.2 centimeters wide, and white matters contain till 100,000 for a millimeter square of actions. This means that the spinal cord is a very delicate structure, and if it isn't working right, it can cause severe symptoms and signs. Among primary central nervous system tumors, spinal tumors account for 3% of them. Their incidence is 1 for 100,000 person years, which means there are 7,000 new cases per year in Europe. The key question we need to ask ourselves about spinal tumors are what is the possible location within the spinal canal and how it affects the histological. We then take a look to the picture in which you can see the axial spine section, and we are going to classify the lesion based on the location. In yellow is highlighted the spinal cord, and the dotted line in red marks the dura. Cerebrospinal fluid is by definition intradural and extramedullary. Lesion can develop within the spinal cord, as you can see in yellow, and it is called intramedullary lesion. Or it can develop within the cerebrospinal fluid and it is intradural extramedullary lesion, or outside the dura and results as an extramedullary lesion. Clinical presentation can vary, and you need to evaluate deeply the patient. The most common symptoms is slow and progressive back pain that can radiate down to the extremity. There are often other signs such as the weakness, loss of sensation in the legs, arm or chest, loss of bowel and bladder function, and rarely autonomic dysreflexia, especially if the lesion is located at or above the 6th thoracic level. In the case of less aggressive and slow progressive spinal lesion, muscular tone and atrophia is often alterated, and we can find also some spinal bone. Based on the location within the spine, tumors can be differentiated in several histological types. The tables list the different histological types according to the site, highlighting malignant tumors in red and benignant tumors in black. Intramedullary spinal cord tumors account for 10% of all spinal tumors, and the most common are ependymoma and astrocytoma, that I'm going to discuss later. Intradural extramedullary tumors are 35% of spinal tumor and include meningioma and nerve sheath tumors, and extradural tumors are often malignant, including bone metastases and sarcoma. I will go focusing on ependymoma and spinal cord astrocytoma. I would like to stress that beside the two histological types, we should keep in mind that also hemangioblastoma can occur within the spinal cord, as well as cavernous malformation, and there are also some mimics as inflammatory lesion, demyelinating lesion, and infarct. Intramedullary tumors can be differentiated by spinal MRI. Astrocytoma is usually thoracic and it extends to 7 segments compared to ependymoma that mostly localized at the cervical level and is long around 4 segments. It occupies the central part of the spine, meanwhile the astrocytoma is typically eccentric. Moreover, the ependymoma is a well-defined lesion with homogeneous enhancement. The astrocytoma grows with an infiltrative pattern and has patchy enhancement. Within syndromic disease, astrocytoma can be found associated to neurofibromatosis type 1 and ependymoma more often associated to neurofibromatosis type 2. Contrary, hemangioblastoma is typically related to von Hippel-Lindau. It is often eccentric lesion, sometimes within an esophytic component that extend for a few segments, exhibiting nodular enhancement. By specific MRI sequence as SY, a blooding component can be detected. Spinal cord astrocytoma are the most common intramedullary spinal cord tumors in children and second most common intramedullary spinal cord tumor overall. Usually they are low grade, such as pilocytic or grade 2 astrocytoma. Among the few retrospective studies on spinal cord astrocytoma, the one published by Lebrun and co-workers in 2020 deserve attention due to integration with the molecular analysis. As you can see by the Kaplan-Meier curve, the outcome differs between high-grade versus low-grade. High-grade astrocytoma patient presented an extremely poor prognosis with a median overall survival of 23 months and a PFS of 6 months. Alteration in MAP kinase signaling pathway are frequent in overall low-grade astrocytoma and even more frequently in pilocytic astrocytoma. In the high-grade astrocytoma, the most frequent mutation is H3K27 mutation, followed by TP53 mutation, mostly associated to H3K27. In the same paper, Lebrun and colleagues did a comparison of the molecular features between brain glioma and spinal glioma. Pilocytic astrocytoma exhibit commonly Ki-AA-BRAF fusion. However, the fusion involves the exon 16 of the gene in cerebral astrocytoma and the exon 15 in spinal astrocytoma. In G2 astrocytoma, EDH1 is the most common mutation found in brain G2 astrocytoma, while is very rare in spinal, and these mutations are not canonical EDH1 mutations. Among EDH1 wild-type G2 astrocytoma, the TET promoter mutation was the most common mutation found in the brain compared to BRAF mutation in the spine. Regarding EDH1 wild-type G4 astrocytoma, the cerebral lesion typically exhibit TET promoter mutation and EGFR amplification that are almost absent in spinal lesion. Conversely, spinal G4 astrocytoma is characterized by H3K27 mutation followed by TP53 and ATRX mutation. The H3K27 mutation is typically described in diffuse midline glioma. It is worth focusing briefly on diffuse midline glioma, a new entity described in 2016 entity. This entity was introduced as a specific nosological entity in 2016 within central nervous system WHO classification and categorized as G4. These tumors most often involve the brainstem in children, while in adults they are located in spinal cord and thalamus, as in these two examples. Both radiological and morphological spectrum varies between the two. The spinal lesion presents as a non-enhancing intramedullary mass with an expansion and signal abnormality on T2 weighted MRI. As you can see from the histological section, there was only minimal hypercellularity and cytological atypia, and tumor cells strongly express the H3K27 mutant protein and also show loss of ITRX expression. In contrast, the thalamic example show a rim-enhancing mass on post-contrast T1 MRI, and histology demonstrated classic features of glioblastoma with prominent multinucleate giant cells. In addition to H3K27 mutant protein expression, there is a strong P53 staining. We are going rapidly through recent study by Chai and colleagues that characterize spinal cord astrocytoma bearing or not H3K27 mutation. They show that although H3K27 mutant tumors are considered as grade 4, histological grade cannot be ignored when assessing the prognosis of mutant spinal cord astrocytoma. Their first study was published in 2020 and described 83 spinal astrocytoma. The median overall survival of histological grade 2-3 mutant cases was significantly longer than that of either the total histological grade 4 cases, as you can see in the figure on the left, or the H3K27 mutant histological grade 4 cases in the figure of the right. Among H3K27 mutant astrocytoma, all are ADH1 wild type and BRAF wild type. TER promoter mutation were observed in both H3K27 mutant and wild type astrocytoma. The same group characterize deeply this tumor. They reported that P53 mutant mutation occurs in almost 60% of the cases and is mutually exclusive with PPM1D and NF1 mutation. They also described some molecular features with prognostic value in H3 mutant astrocytoma, such as the higher number of copy number events, the 9p deletion, the 10p deletion, the ITRX mutation, CDK6 amplification, and RB protein pathway alteration. We are going to present two cases that are intramedullary lesion and got regular assessment in our institute. The first is a 20-year-old female that complained cervicalgia. She underwent 2 MRI that show intramedullary lesion. She then underwent to surgery that and histology concluded as a pilocytic astrocytoma with BRAF fusion. She underwent to regular follow-up for 17 years with the stability of the disease. After 17 years, there was a recurrence and she was treated with radiotherapy, and 5 years later she got another local recurrence and we started treatment with temozolomide. This is the case of a 58-year-old male complaining left hyposthenia and right hypostasia with G5 level. He underwent 2 spinal MRI that show intramedullary lesion at C3, C5 levels with hyperintensity dual signal and mild contrast enhancement. Within a few months, he got cervical surgery. Histology show grade 2 EDH1 wild-type astrocytoma. No adjuvant therapy was started till 2 years ago when he experienced clinical progression associated to radiological progression, and he underwent to local radiotherapy. The therapy of spinal cord astrocytoma is still largely under investigation, and there is no consensus about it. 2 years ago, I and my colleagues did a systemic review on it. The systemic review was based on a literature search performed in PubMed from 2000 to 2021, including studying on spinal astrocytoma related to adult patients with histological confirmation, at least one outcome, and at least 6 months of follow-up. A total of 285 adult patients with astrocytoma were identified. This slide summarizes the main data we collected, and you can easily find any details on the publication. I'd like just to stress that we could not find any clinical trial on spinal astrocytoma based on the rarity of adult astrocytoma and the limited number of the studies available. The literature did not provide enough data to determine a recommended treatment plan from spinal astrocytoma. This is the flowchart that usually we follow in our institute. After a suspect of spinal astrocytoma diagnosis by MRI, we do a surgery as large as we can. If there is a gross total resection and histology is low grade, the patient undergo to regular follow-up. If the histology is grade 4, or if the patient got partial resection or biopsy, usually there is an adjuvant radiotherapy. Systemic drug is usually used when the disease recurs, and it can include alkylant or other antityrosine kinase inhibitors, and we are still waiting to get some results about some other experimental approach, including H3K27 mutant targeted approach. The ependymoma is the most common intramedullary tumors, as I mentioned before. However, I'm going to talk very little about this entity because of a specific lesson will be prepared by my colleague, leader in the specific subdomain in EURACAN network. Ependymoma usually affects 40 years old male and female, and has cervical spine location. The grading is mostly grade 2, as well as rarely we can have also grade 3, and it is often related to neurofibromatosis type 2 diagnosis. On the illustration, I summarized the new 2021 WHO classification of central nervous tumors that defines 8 specific types of ependymoma and 2 additional types that comprise tumors with specific locations but that cannot be assigned to another molecularly more specific type. Together, 10 different diagnoses now exist to classify ependymoma tumors. In the present slide, you can see an overview of the key characteristic and diagnostic criteria of the distinct ependymoma tumors type. In the spine, we can find 4 different types, including spinal cord ependymoma, spinal cord ependymoma with MYC amplification, mixed papillary ependymoma, and subependymoma. As you can see in the column of the outcome in red, you can see the most dismal prognosis, and it occurs in spinal tumors with MYC amplification. Among the spinal ependymoma, the ependymoma bearing MYC amplification are the most aggressive. The histogram depicts the age of onset at first diagnosis with a median of 32. In this specific type, the lesion is often extramedullary intradural, as you can see in the picture of the schematic transversal spinal cord. And most of the tumors are metastatic both at the time of diagnosis and at recurrence. About the outcome, the median PFS of this tumor is about 17 months and was significantly worse than for the other subtype, as you can see on the left. The same happened also for the median OS. Here are summarized the guidelines about ependymoma therapy, and I'd like to stress that is still the main challenging are about the MYC amplification, how to address this subtype of tumor, and which role has the chemotherapy and the target therapy. The take-home messages are that spinal cord tumors are classified by location. The most common intramedullary spinal cord tumors are ependymoma and astrocytoma. In younger patients, more likely astrocytoma occurs, and it is at the thoracic level. In older, it is more likely to find ependymoma at the cervical level, probably associated to neurofibromatosis type 2 syndrome. They differentiated by MRI imaging. There is consensus about ependymoma, and different guidelines are already published, but still there are no consensus about treatment in spinal cord astrocytoma.